Yeah, good afternoon for everybody. Thank you very much for the faculty for invitation for me. It's a great pleasure to be here. It's my 5th time in Egypt. So today and now I would like to share with you my thoughts about the tips and tricks in partial deafness treatment. So this is the situation which is for the patients which they have some residual hearing, and we would like to preserve that. And the beginning of that started in general in whole cochlear implant programs in 70s, in 80s, when there were 3 ways. One was the French one, second was Australian, third was the Austrian, and of course US. And there was discussion about how to make the hearing preservation possible. So it went on that way. And then there was in 70s and 80s the other group of surgeons which liked to analyze if the insertion is only for insertion or is is the important from the placement of the device. Placement of the device means that when we insert the electrode earlier, there was quite often the only posterior inferior approach, and there was a big damage of the cochlea. So our story began in 1992 when there was the first cochlear implantation in our country, and there was different times. Of course, there was the beginning of a new history of our country. There was the change of the system, but also it was the chance of success to change our approach and to set up the center. Till today, there was over 12,250 implantation, so that material is quite relevant. Our first presentation of that residual hearing was in 2000, when there was this presentation for the group in children in Antwerp, in European Pediatric Cochlear Implant Congress, and then several months later in EUFOS meeting, which was in Berlin, when Professor Lawrence presented from audiological point of view of that. It was the initially how it was divided in the groups when there was the good hearing. Let's see the laser. When there was the good hearing in low frequencies, you can see here, there, and there. And in general, we thought then only about the pure tone audiometry. Pure tone audiometry. So we analyzed, of course, the speech understanding, but it was not, very important in terms of the length of the electrode. After that, we started to analyze the speech understanding in different conditions, in different tests, and to that we adjusted the length of the electrode. And this is the strategy which more or less started in 2010, and this is the surgical procedures which we present, and it consists of 6 steps. First is anteromastoidotomy. We can hear in the former session, when it was at 3:30 at 10 a.m. regarding the cut. So today the cut is quite small. It means that we need to be with some distance behind the pinna. We should not be on the cartilage. And very important is not only how to make the cut, but also the mobilization, how mobile is the skin. Because, for example, in children, especially, I always put the big finger on the tip. I check how is the mobility of the skin. If this is too much mobile, I make a little bit more distance to the cut, because I don't want to go to area when there could be the facial nerve. And if we can preserve that superior part of the cut, is always nicer. We don't like to make it in one line. And after that, I make the line. I inject the lidocaine and some medicaments to later have better it from the bleeding point of view. And always I would like to have such line. And we make one cut. The first cut is with the knife. After that is the monopolar coagulation, and we cut also the subcutaneous tissue and periosteum in one line. After that, there is the anteromastoidotomy. How it has changed. It's that what also I underlined in the previous session. Today there is no need for make big cut and opening. We take the bony cap which you saw earlier with chisel and hammer. It's important later to close the gap, but for some surgeons they don't use that, so it's also not a problem. And as we can see here, we start from the big cutting bar. It must be presented the posterior wall. This is a very important landmark. So we need to know that exactly this is the posterior wall, not to drill too posterior, because we could go to the sigmoidal sinus. And the issue is your experience is always measured. More experienced you are, a little bit inferior you go. If you are less experienced, you need to drill out that triangle, that almost up to the dura. Not to the dura, we don't need to go to the dura, but we need to open the mastoid as much to have better view, better lighting, and then better access to the area of posterior tympanotomy. And as we also could see, that when there is obliterated mastoid, this is ossified mastoid, it's good to know how deep we need to go, and if there is any aerated cell, if no, we follow always that line from after the posterior wall. If not, we go superior and posterior. We never go in that direction here, because here you will, at the end, you will find the place which could be the cavity, and you will be semicircular canal. The issue is when there is problem is that when you drill with cutting bar or the diamond bar, and you start to feel that there is different consistency of the drilling, that is something harder, something different, something strange. It could be semicircular canal. To go through the semicircular canal, you need to drill really much harder. The most common mistake for residents and for the beginners is that you go inferior, anterior, and facial nerve goes in that area from behind it's the short process of the incus. It could be visible in the moment. There is a facial nerve, and it goes somewhere here. And then if we drill here, we could make the injury of that. Sometimes happens that we make nice posterior tympanotomy, we make nice antermastoidotomy, and later we have not enough space, so we could go a little bit superior here with the drilling. And the moment when we need to think that we are too high is when we have some more bleeding from the bone. It could be the moment when the bone is, we are close to the dura, and this is quite important. Posterior tympanotomy also has changed that approach, because in 90s, even 25 years ago, some surgeons, they performed that, they took out everything from there. They would take an incus, and it was big cavity, and that was easier. Today we try to preserve that, I repeat that, we try to preserve the bone bridge. We go from 2.3, and in that moment when we drill out a little bit more with 1.8 diamond bar. So this is the size we don't want to go with 1.0, 1.2, sometimes with 1.4, because we would like to widen more that. If we go with too narrow, too small bar, we could go easier to the facial nerve canal. What is also important, if we take out the bridge, the bone bridge out, it's easier for the beginners. You can do this. In some cases, 2-3 times per year, I take incus out, honestly, because sometimes I have, not visible the round window. It happens very rare, so it could be like that. So this is the view of the ears. So we have semicircular canal. We have the short process of the incus, long process. This is the stapes. I don't like to cut the tendon, because there will be the bleeding. And this is the area which I would like to analyze before drilling out. This is the round window niche, and I always check in the CT scan when there is round window, when there is facial nerve. It's here, if it's here, if it's here, or if it's here, because then I know how brave I could be. The more brave I could be, I could do it faster. And it's not only to be brave in terms of the drilling, how fast I'm in the drilling. The most common facial nerve problems are not because you go through the nerve. Of course, it could happen. Is because you hit on the nerve, hit on the area of the facial nerve. So this is the proper irrigation. We always perform the irrigation is separate from the drill. It's for surgeons, you are not as independent. You need to have good nurse or resident who is doing that irrigation. It's not easy, but it's more flexibility with the drilling. The bar is more relaxed. Here sometimes, as you can see, the chorda tympani is not so much visible there. There is no need to visit the chorda tympani. But if you have inflamed ear, if you have spikes, adhesions in the posterior tympanotomy, They should be never underestimated. What does it mean? That I clean that always, all that spikes with the needle or with the hook, because if it's connected with the chorda tympani and I put the bar and I start to drill, it could influence and it could be reflected in the some disturbance regarding the chorda tympani. What could be here more important? If there is a situation that we would like to put the perimodular like 632 electrode, I always make it as thin as possible, because I need to have better approach to put the electrode, because if I have not less straight angle I have, there is more risk that electrode will go up and there is more risk for the translocation and for the deep fold over. So with the perimodular electrode there is need for make larger opening, and also with wing electrodes like Slim J, if you make it too small, then there is need for make later less visibility. How big should be posterior tympanotomy? Posterior tympanotomy should be as large that in case of any problems you could put two tools. So there is electrode, there is forceps, and if it's blocked, and the last part you could support with suction or with the hook to put the electrode inside. So this is important, that you need to put two tools, because if you are stuck in you have last two canals out, and then you don't know how to do, to go in, to push, to go out and again, to enlarge. Majority of the surgeons, they stay and they lose the two electrodes out, for example, but it's also a good solution. Sometimes we try to change the direction of the insertion, but it will not go. It's better to, from the discussion in one of the surgical advisory board, there was the conclusion that it's better to lose one or two electrodes out than to push it in force inside, because it was more often the failure of the electrode, that it was broken, bent, and the contacts didn't work. So this is how it works. Another issue, the enlargement of the round window niche. I always check which electrode I would like to put. If I would like to put the standard electrode, there is 1.3 millimeter, the basal part. If this is flexi, 0.8. If this is, they are like Slim J or they are perimodular, they are 0.7. So if I would like to put standard electrode, I enlarge bone overhang larger. Because later when I put I insert the electrode, and the last moment either I will push it through, or it will be blocked. So there are some small tips and tricks. Not so often the situation is such nice like here, because here we can see this is the semicircular canal, facial nerve is there. It's very nice and very inferior approach to the round window. An ideal solution is to open it after the bone overhang is taken. Bone overhang we take out in, I think, 98% or 97% now. It's not as earlier than we wanted to push it through the round window. Now we see the round window, but we want to enlarge that bone overhang more, but we want to enlarge only bone overhang. We don't want to go more like round window extent approach, which is possible, but not in all cases. And ideally is to open it small, but not very narrow. It is the theory which I have no proof, but I agree that we have the pressure. If we put the electrode and there is a volume of the electrode in the cochlea, there could be some pressure in the fluid. So it's better that fluid could go out a little bit. So it's good to be not very small opening. And in terms of the steroids, we don't push the steroids to the cochlea. We put it intravein. These several studies about putting the steroids, and also there were some studies from Plontka, there were studies from Belgium regarding how the dexamethasone solution comes to the cochlea. And quite often, if we apply the dexamethasone solution here, it will go only to the basal turn, which is very important for us in terms of the cochlea, but the hearing preservation, that's what we would like, is more in the more apical region. So now there is not as wide opening, because the electrodes are more flexible, they are nicer, heavier. I saw in video that like with a ring nucleus electrode, when that electrode bent, it was it bent, so it was not easy. Today we can work that with electrode. And always is too good to have the proper electrode. So the approach to the scala tympani, here you can see, this is the, of course, Slim J electrode. And you can see that we need to position that towards the modulus, the active canals, and that electrode must be a little bit more enlarged, the bone overhang, because that wing is quite strong. So when I show electrocochlearography study, we push it deeper and we have not enough space, there is risk for migration. Migration means that electrode goes out from the cochlea. So the electrode we need to push, so from the sleeve J, we always make more enlargement of the electrode. And also there is the situation which happens more with mid-scala, that when you put the electrode, it has tendency that sometimes it's turn out to the opposite. So the contacts are opposite modulus. So we need to be careful on that. Electrode fixation. We always fix the electrode with the small part of periosteum or the fascia with the dot of fibrin glue. And the first part is go inferior, then we go superior, and then we close the posterior tympanotomy. It prevents from migration of the electrode. From the study which was published in Frontiers by Paul van den Heining was the first author, that what is minor in the straight electrodes and perimodular is that straight electrodes has tendency for migration in several percent. So electrodes goes out. So we want to block that electrode, but before we block, we check and see if there is tendency that the electrode goes out. So that's why we always like to seal that, but there is issue that we should seal on that way that it will be not intact with the ossicular chain to prevent from the conductive component of the hearing loss. Fixation in the bell, quite important. We need to separate the wire from the posterior wall. We put the sponge with antibiotic, which is quite important, and we put the fibrin glue. So we close that, and there is fixation of the electrode later in the periosteal pocket. So it was discussed also in the session earlier that we like to enlarge it not as big as there is the receiver, and we push that receiver to the periosteal pocket. So we don't want to enlarge much the separation, the periosteum from the bone. In some cases, when you have emissary vein, when we have situation anatomically different, we do that and we smoothen the surface, and we always make the indentation, so the groove for the wire. This is the must, which is always performed. So now we have different size of the electrodes. It's always your choice which electrode you choose. You know, there was discussion around table in the cochlear implant meeting in Las Palmas, and some students said that for them the most favorite was the standard electrode. Standard electrode is nice, but I'm on the one hand I like, but on the second I'm not big fan of that, because you need to really open the round window, and bone are quite large because it's 1.3. But it's more stable when you insert that, and so there's less risk for bending that. So the Flex 28 Flex Soft is more difficult than Flex 28 because they are more dense electrode. I remember Kevin Brown from the Manchester. He said that he frozen the electrode. He freeze to put to the refrigerator that is colder, so there is not as flexible. That electrode also has the contacts on the one side. This is that compressed electrode, which is more often used in the ossified cochlea. So you can see that channels are very close to each other. Sometimes we don't turn on all of them, and it looks like that. And there is also the possibility to have medium electrode, which is nice for the cases with the gusher, so you can plug it. We have for gusher, we have from model form 24, form 19 is M, and also we don't like to use the stylet electrodes for the gusher, but there is issue that it could be later the problem with the connection between middle ear cavity and the inner ear, yeah, and the gusher we need to really plug in. And the idea of Levens and Aroglu was very nice with the form, but we need to really make big posterior tympanotomy because that cork is quite big. It's not easy to put it. So today, according to that, we check the size of the cochlea, we check the length of the electrode, we check of the speech understanding. And quite often, if you have even a residual hearing like that, which is quite nice, and speech understanding is on the level of 10, 20, 30% in best aided conditions with hearing aids, we prefer to go deeper. The histological study which are very nicely presented by team like Helke Arask-Andersen or Agrawal. They present, and also the study from Hanover, for example, that all the story began over 20 millimeters, more or less, because there is the resistance of the making the electrode inside. So till 20 millimeters were quite safe. And the insertion, which is also now in review, the publication, is that we change the strategy in terms of insertion. We don't make one constant speed of insertion. At the beginning, we make normal, let's say, and after the 20 millimeters, we significantly decelerate of speed of insertion. If we feel some resistance, we go a little bit out, we change direction clockwise or other counterclockwise, and then we put there inside the electrode. We did this at the publication 19 when there were two groups with the same hearing like that, Flex 20 and Flex 24, and what was the conclusion? The hearing preservation was better in Flex 20 in terms of the audiogram. But in terms of that's not the slide. Okay, but in hearing preservation was better in Flex 20, but in speech understanding was better in Flex 24. So always we have that, we go a little bit deeper, but of course not too deep. Even some colleagues, when they do ECOG, would like to go much deeper. There is some presentation of electrocochlearography, which according to that criteria of the hearing, and you could see that this is 250, the red one, this is 500, and we in publication, which is, I'll show you which publication is that. So we cut the surgery for second by second, and we analyze what could influence, and they really changed our strategy of surgery recently in the last years, because you could see we put electrode inside, the measurement is of the top electrode, there's acoustic signal from the external matus, and you can see there is significant increase of the signal, so the hearing is very nice for preservation. A release of the forceps, so when we make the hand, make the forceps, and we release forceps because we feel some resistance, you can see that this is decrease of the signal, this was high resistance, and it was changed 1/4 of the turn in the clockwise, and it went a little bit down, but here you can see that the 250 increase, even if 500 decrease. There are two reasons. First, that 250 is very important, and that for the hearing preservation. Second is that the measurement is from the place of the top of the electrode, so we went over the place of the measurement. So you could see that this is this is one thing on the slide important. This is the packing. Quite often we observe that we have decreased signal during we pack, so we make the sealing. So we never underestimate the sealing. This is another case. This is the publication when you can go through that. And also there was a study with metal. This is the study with AB. Also you can see there is the tip in round window, this full insertion, electrode sealing. There are some movement of the electrode, but this is a very nice tool, and we later estimate the audiogram. It's a very interesting tool for looking how we could make the surgery, what we could achieve, but we don't do it routinely. So in general, for the clinical prospective study, we observe that, and you could see that if we go from 3 to 15, that level is very nice. On Monday we have live surgery, so we have not 15 but 150. It went up and then go down to 20. So in the graph it looks that it was decreased, but it still was very nice hearing preservation. Another issue is to make unilateral, bilateral. Of course, everything depends on criteria in each country. It's not easy from reimbursement point of view, and we can have, there are results of the patients with the bilateral EAS, PDT-EAS case, so you could see that it was complete and partial hearing preservation was activation, then the hearing decreased after 3 years, and there was second ear, which was implanted more or less after 5 years. So you could see that the hearing was not possible to preserve as good as in that ear due to the reimbursement issue. But you can see that these unaided cases with preparative hearing aids, with strong BTE, first implant alone, second implant alone, and bilateral. It's also because we have audiogram, but the situation in the cochlea and in the middle ear changes. So first, we have more ossified round window approach, so we need to drill out more. We have more bony particles which could influence on the hearing preservation, and in older we are, there is a worse chance for the hearing to preserve. So we have also pediatric cases, very few. This is only 15 cases like that in our that. So there were patients with very fast progressive hearing loss. So it was fast progressive hearing loss. We observed that we exclude gusher, so we exclude enlarged vestibular aqueduct, but we make the operated ear. What is not in publication, the ear which was implanted has low decrease of the pure tone audiometry than the non-implanted ear. So in non-implanted ear was faster deterioration. So it's electric autoprotective effect of insertion. So it's another study, but you could see that in children is much better because it's always a little bit easier for making that. So there is, a lot of discussion about that in terms of the complications. I have 4 minutes, so I will not talk about everything. We have complication diagnostic, surgery, healing period, and delayed post-op. About nerves, that's what I could underline. We make cross-checking. If we have doubts, we make MRI, but quite often in our radiologists in our country, often they write they could be or could not be nerve, and then this is your choice, what to do. But if we have any response in ABR or any results with hearing case, we go for implantation. We go for deeper always insertion till the end, and we quite often meet that there will be some difficult case in terms of the stimulation. In terms of inflammation, we try to avoid such situation, but if we can make insertion. If we have heavy inflammation, we try to avoid. We try not to make simultaneously adenotomy and cochlear implantation because it's a big, effort for the body. So we try to divide that, but it's possible to make when there is otitis media, and when is that we put in general stronger antibiotics, so like cephalosporin third generation intravenous, and it's like that. That's what is, I think, what I could say in that 3 minutes. In gusher, when you have gusher or you have oozing, the flexible electrodes are very difficult sometimes to insert. When you have heavy gusher, it's sometimes difficult. So you need to have a little bit stronger and shorter electrodes. When we have we have the CSF leak of sigmoidal sinus problems, we have the modified cellulose, which we put, like these neurosurgeon materials, which we put in fibrin glue to close that. And displacement of the device. This is the last thing which I could discuss. This is if we have any situation like that, small, that we never understand, we need to work fast. In many cases, the recommendation now to explant, to cut the electrode, to lose the electrode in the cochlea, and when we will reimplantation to take electrode out and make new one. If we see, we try to start to quite fast as possible to change the position of that. Not in all cases is successful. So, it could be the problem. And in cases like that, we need to explant the device and wait at least 3-4 months to make the new one. And such idea on the patients that, okay, we take it from that ear and put to another ear is really not enough clever. I think I'm open for your questions regarding that. We have 2 minutes from information more, and of course I would like to invite you for our meeting, which will be in April, and the cochlear meeting, which will be in 2026. Thank you very much for your attention. Any questions? Anybody would like to ask something? Mm-hmm. The question was if we prepare the bed, we prepare placement for the device, or we make periosteal pocket. Earlier, we always did the bony bed. When we enlarge, we elevate the periosteum. Quite often we made some emissary vein, especially we would like to make more posterior. Today, we elevate that, we make indentation, we make a groove, and the initial part, so part which is closer to the ear, we smoothen. So we make that like that edge. So that the will implant not go that, but we don't make the fully bed, because fully bed means the fully elevation of that. If we, in some cases, if there is thin skin, if we need to do, I like to put the vacuum. So put that, make the bed, and to prevent the bleeding and the hematoma, I would like to make the vacuum. And I make and for 2 days, and then it will be with that sucked vacuum. There will be nice, healing. But if we make like 10 to 20 implants per day, and we have 5 kids with vacuum, 5 with no vacuum, mothers are crazy at the corridor. And to explain them that you have vacuum, you have no vacuum, you have that, is sometimes very difficult to tell. So we from that point of view, started to, smoothen that and not to make vacuum only in the very difficult cases. But it was something what I liked. The kids, they started to take it out. So when we make the bed, when was the bed, more often hematoma happened in the anterior superior part because we need to elevate that. So that's why we modified a little bit. And the second thing, we have nicer implants. They are, not 8 millimeters, they are 4 millimeters, 5 millimeters. So there is not as much need to do that. Another issue in terms of the bed is that if we have patients with BMI more than 35 or subcutaneous tissue is more than 8-9 millimeters, it could be difficult from magnet point of view. And on one hand, we can recommend them to go down with kilograms, but they say, okay, also you could go down with kilograms. I said, yeah, I agree. It happened to me one time, but I said, if I need to cut the muscle or something there, it's really nightmare surgery. It's not nightmare, but it's the bleeding. This is the later problem. So I don't like to do. I had to do this with Baha Attract earlier, so it's done.
Dear doctor, you...
Yeah. Yeah, the infection, yeah. Mm-hmm. Good bandage is important. My bandage is
Your time is up.
So I immediately know that it's my patient.
Dear doctor, your time is up.
Small child with the facial, a little bit deficiency. It was the congenital malformation. So I immediately write them to come, and we put them 0.5 milligram steroid per kilogram, and it went out. The strong bandage is really
your time is up.
It's worked. The hematoma happened more often in COVID,
Dear doctor,
honestly.
Your time is up.
Home, and they have, I don't know why, but in COVID we have more hematoma. The children typically, bump, they were, I don't know what's happened, but it happened more often.
Dear doctor, your time is up.
Now it's okay. In COVID was more. Okay, thank you very much for your attention, and I open for your questions in the after.
Dear doctor, your time is up.